have listened to the talk of Professor Lucas, the Dunning tubular effect. It is definitely not in my case. So I will just present why I prefer TOPE. This is my feeling and this is how I feel. So if you are not good at one of the procedures and it is causing problem for you, you search into the evidence, either get more practice, more training, or switch on to something which suits you. So that is the idea of my presentation. So you all know what is fundoplication. I will try to be quick in the slides because of the time constraints. So it is just to reinforce this esophagus by fundal lab, either anterior or posterior, and to strengthen the lower esophageal sphincter, to restore the anatomy and reduce the reflux. And I will share my perspective on fundoplication, why TOPE, and why it stands out for me. So the literature is rather scarce in defining a gold standard for this kind of procedure, fundoplication. One of the reasons is most of these procedures are taken over by gastrobutyral and PPIs. So PPIs have taken these procedures out of the surgeon's hands in most of the cases, except in patients who are non-compliant or do not respond or remain symptomatic. So quality of evidence which is available has constraints because of the either small sample size or lack of standardization or problems in objective outcome assessments. And the pool analysis had their own again problem because of heterogeneity. Because of so many modifications in different procedures. Even in Nissan, there are more than 10 modifications as does the TOPE as DOR and CAR and all these procedures. So there are anatomical types, and type 1 is sliding, everybody knows, and about 95% of the hiatus hernias belong to this type. And the rest of the most belong to type 3, which is a combination of 1 and 2, with both the gastroesophageal function and the fundus and hiatus, and about 90% amongst 1, 2 and 3. And then other structures becomes type 4. So pathophysiology is just weakening, reduced elastin and proximal displacement for gastroesophageal function, and most cases are acquired and they're not. So I went into the literature just to support what I'm thinking and what I'm presenting and why I'm presenting for, is that hiatus hernia can be diagnosed, okay, for diagnosis, if you are good in endoscopy or just barium swallow, it's good enough. You may add a CT scan if you think there are other structures inside, but manometry is really not required in all cases. The repair of type 1 hernia in the absence of reflux disease is not mandatory. So this is important for surgeons. If 95% of the cases are from type 1, and most of them they are asymptomatic either because of the drugs, PPIs, or other asymptomatic, you don't need to operate. That is a strong evidence. All asymptomatic parasogenital hernias should be repaired, or symptomatic, sorry, and routine elective repair of completely asymptomatic parasogenital hernias will not always be indicated. So there are strong evidences available in which you have to select your patient, and patient selection is the prime importance whenever you select these patients for these kind of repairs. The mobility of a laparoscopic approach, of course, this is the proponent that a laparoscopic approach has a definitive advantages over the open approach. So reduce mobility, reduce hospital stay, and the use of mesh has a little recommendation. There are problems associated with mesh. Some people think the mesh should only be used for large parasogenital hernias, not in all cases. So fundoplication must be formed during repair of hiatus hernia to address reflux. That is the single most important thing. It has to be for reflux. In the absence of achalasia, so some of the patients actually have background of some utility disorder, and the most common utility disorder which may be missed is achalasia cardia. And the necessary step of hiatus hernia repair is to return gastroesophageal tension to infradiaphragmatic pressure position, which is very strong evidence, and there has to be 2 to 3 centimeter left. So there is not very strong evidence, but still we need to have some intra-abdominal esophagus. and hernia reduction with gastropexy alone. So this, I was presenting somewhere else topic, and somebody asked me, why don't you do just gastropexy and get away with that? And people have done it. But gastropexy is reserved only in those patients who are not fit for a major surgery or a prolonged procedure, but it has a high recurrence rate if you do it in all patients. So there are types, the anterior and the posterior. There is one other type is from the thoracic. Actually, I started by first or second fundoplication by Belsey Mark 4. Belsey Mark 4 is a thoracic approach. I did it first at Mayo Hospital when I was senior registrar in emergency. The patient had actually volvulus of the stomach and there was a large parasocial hernia. And I did fifth intercostal enterotomy and managed to do that, though it was difficult. But you see, then I converted into abdominal approaches, and then my first few cases of were Thal procedure. And Thal was anterior wrap. Actually, it was a seromuscular wrap, and I used to do it in patients with severe strictures. And when the gastropupil came in, we were short of severe strictures. They did a wonderful job by dilating them, and we just left with esophageal or middle or higher strictures, which are not amenable to endoscopic dilatation. So there are anterior and posterior Nissen. I used to do Nissen, but I had two problems. That's why that I'm going to discuss, and that is the reason I converted to topic. Door, Watson, and Thal, all this. Door, I do it only for aplasia cardia. I don't do it for any other procedure. It is just a wrap on the lateral aspect of the esophagus, and it is really done. So there is a large meta-analysis which was available to me, and that indicates that TUPE is slightly better in terms of complication compared to Nissen fundoplication. So why? So that is the reason. After this, going through the literature evidence and all those things, why? So I think post-operative dysphagia was one of the problems. I went into many times into my procedures and thought, what is the cause? Every patient or every other patient gets dysphagia. And I think probably after discussing with people, probably I am making smaller window. The posterior window I make, I will show you the video. My window is probably smaller than the people who are happy with it, that it's probably not that floppy. That's what I think. When you go back into the procedures and think what you are doing, what's going wrong and what you are doing bad, I think you have to do it. So, but making a larger window has its own problems. It can cause migration of the whole thing, either into the chest or lower down. Gas load is another problem. So that was one of the reasons. So just going quickly through the technique, so I'll give you a quick tips and tricks. The position has to be supine with 10 to 15 degrees sternum position, 10 mm primary port and 4 or 5 mm ports. 2 ports for the dissection, 1 for the liver retraction and 1 for the assistant. For the traction of the esophagus and gastroesophageal retraction. So first, what you do everyone do it, plan for any difficulty. If you get any adherence, problems, difficulties, plan first. And don't enter into the field before you plan. Sometimes you have to plan right away to open it up. Liver retraction, incised, I start with pars flaccida, mobilize esophagus and gastric fundus, expose pleura, reduce lateral hernial contents, approximate pleura and fundal lag, which is, these are the positions, very typical positions which I use in this patient as well. Supraumbilical is very important because if you put your primary port in umbilicus, you are far ahead, far up, and it's very difficult to reach there, and you are in trouble. So you have to go about 4-5 centimeters above the umbilicus or according to the size of the patient. So a right position, a right insertion of the ports will give you a much easier your economy and everything. So I'm presenting 47-year female with BMI 30 with all GERD and inflamed esophagus, gastroesophageal rejection of grade B, hernia, type 1, no significant morbidity, and so this is the procedure. So what you do is I just use, in this case, sometimes I use Matheson retractor, but in this case I use simple retractor. I start with pars flaccida, and you can see the fundus and this gastroesophageal junction was up into the chest, posterior mediastinum. And what you do is start from the pars flaccida, which is almost a vascular field. You go up. And the first objective is to identify the pleura and make a posterior window. That is very, very important. So just incise, keep on incising up to the hiatus. Incise all the peritoneum around the hiatus. That is very, very important. Be careful for the vessels. Because which is very important is your traction. Traction has to be in line with the esophagus. And you see again and again, I'm very careful in traction. It has to be in line with the esophagus. If your traction is not in this line, you will be again in trouble. You just keep on doing this and that, and it doesn't work for you. And you can see this area was all in the chest, and you just pull it back and just start making a posterior window. And you can see a small part of the sac here as well. And once you make a reasonable posterior dissection, then you go on to the other side, so as to make a section from the opposite side and inside the peritoneum. And then one of the reasons I switched into tope was again short gastric vessels as well. You don't have to divide short gastric vessels in all patients with tope. And I had one conversion of Nissan only because of the bleeding from the world's short gastric vessel from the spleen, and it was not manageable by the first one. And here you make a window here, and you can see you make a window past your grasper to the window. And I use glove, cut glove for detection. This is sterile, and just make a traction. Again, the traction has to be in line. That is again very, very important. And you can see this part. This is the sac, which is wrapped from the waist to the injection, which is present in the posterior intestinum. And then identify the pleura. This is the left crust window, and this is the right crust and the left crust. So you can see that both pleura has to be very clear, and that is the key. If you are not able to identify the pleura, the peritoneum is still over there, then you are not able to do anything. And then the next is to approximate the pleura posterior. You can make 2 or 3 stitches. It is up to you, but mostly 3 stitches. In this case, it was not a very large sac, so I just ended up with 2 stitches. जो चीज़ इसमें बड़ी इम्पोर्टेंट है खासतौर पर for the PGs is to proper hold the. अगर आप इसमें देखेंगे where you hold the needle. For a proper sutures, you need to hold the needle at 2/3, 1/3 junction. और ये अगर आप ये नहीं करेंगे, you hold it in the middle or hold it somewhere else, you will not be able to apply the proper sutures. So that's how you do it. You apply first suture in the pleura. I think I will finish in 5 minutes. This sutures मैंने सिर्फ इसलिए include किए just for the PGs, just to see how you like. Unless until you are able to make intracarporial suturing in laparoscopy, you can't advance your scale. That is the key for multiple reasons. One of the reasons is cost. In many, even I do intracarporial anastomosis. I do it. I don't use staples most of the time because they're expensive. So it is so important for anyone who wants to do laparoscopy, advance his or her skills. You have to learn intracarporial suturing. इसके अलावा कोई हाल नहीं है. And you don't have to be like open. You just go slow. Doesn't matter. Going slow actually gives better speed than trying to be fast and end up with बार-बार करेंगे और ज़्यादा time लगता है. So here you find, you see, you find the 2 sutures, approximate the pleura posteriorly, and here you can see 2 suture 1 and 2 sutures, right pleura, approximated, and here you find it that you have to have at least 3 to 4 centimeter length of esophagus intra-abdominal. And then you bring the fundus posterior to the esophagus, in the lower esophagus, so that you deepen what I do is in addition to the wrap, which is about 270 degrees in this case, or in any tope, I also stitch with the Tura. I also stitch frontless with the Tura so that it should not migrate up into the chest. So, and then try to be a little floppy. That's what I do. And that is one of the reasons again of my not doing listen very well, I think, is a short window. I just like to. So my first suture pass from stomach to the dura. You need to have a very good bite. अगर आप छोटी bite लेंगे तो just cut it. Just make it a bit forward. And then you apply sutures with the esophagus. It is important here to avoid vagus nerve. Vagus nerve anterior fasciopathy can easily be taken in sutures and cause problems. And one of the reasons for again clot and problems in post-operative. So you have to be very, very careful in identifying and taking care of vagus nerve. Once you make a right fundus wrap on the right side, remove the sling and then make sutures on the left of it. So again, you have to worry about it. This is the gastration injector that I am applying the suture at present. So that is the completion, 70 degrees along with hitch stitches on the Tura. So just to conclude, tope as effective as listen. In concluding, this is evidence. In my hands, tope is probably slightly better. And it reduces dysphagia as well as gas load. Too early and too little to serve. I can't make it a statement because of a little bit smaller experience. कहीं भी दुनिया में इसका बहुत huge experience नहीं है somehow. And at least in my hands, so far, so good, and the teacher's portrait. Thank you very much.
Thank you very much, sir, for excellent presentation and